So I'm going to introduce our first speaker. Dr. Ginger Sabley is a family nurse practitioner with a doctorate degree in nursing practice from Case Western Reserve University, where she was honored with the Dean's Legacy Award for her research on Morgellons disease. Dr. Sabley is a certified applied clinical nutritionist and uses an integrative approach to patient care. She has treated thousands of Lyme disease patients and close to 1,000 Morgellons disease patients since she began specializing in these diseases 15 years ago. Patients come to her Washington, D.C. office from literally all over the world. Dr. Sabley was one of the first people in the United States to advocate for Morgellons disease and to assert that the disease was not psychiatric but infectious in nature. She was honored with the Texas Nurse Practitioner of the Year Award in 2004 and the American Association of Nurse Practitioners Award in 2014. Dr. Sabley is considered to be one of the top experts in the United States on the diagnosis and treatment of tick-borne diseases and Morgellons disease. She speaks and publishes frequently on both these topics and is a referral source for practitioners around the U.S. Dr. Sabley has been on the advisory boards of the California and Texas Lyme Disease Associations, the Morgellons Research Foundation, and the Charles E. Holman Morgellons Disease Foundation. Her book, Morgellons, The Legitimization of a Disease, was released in November 2016 and is available on Amazon, and it's also available right here at this conference. And I can highly recommend everyone be sure to read the book. I'd like to introduce to you Ginger Sabley.
Okay, here we go. Good morning, everybody. I seem to have come down with a cold over the night, so excuse me, I hope I'm going to be able to talk loud enough today. First of all, I want to say congratulations to Cindy on 10 years of doing this and keeping it together, and this has been hard work to do 10 conferences in a row, and nobody really knows how much Cindy works for these things. You know, she is like, it's amazing, and she doesn't feel that well most of the time, so we all need to give her a big round of applause for what she does. I know. I appreciate the heck out of her anyway. So today we're going to talk about a little bit about the objective findings in Morgellons disease. And first, just a little bit about what the difference between subjective and objective findings are, because not everybody here is a healthcare practitioner. The subjective findings are what the patient tells you. So the person comes in and says, I have a headache, or my joints hurt, or I feel crawling and stinging and biting sensation. And these are very important bits of information, but they're subjective in what the patient tells you. So those are the subjective data. And then we have the objective data, and these are the findings by the practitioner. They can either be lab or x-ray results, or just the things that are found on physical exam. So both the subjective and objective findings are important when making a diagnosis of Morgellons disease, because the diagnosis of Morgellons disease is what's called a clinical diagnosis. And you know, there actually are many diseases that have clinical diagnosis, because if we don't really know what the causative pathogen is for a disease, let's even say MS, multiple sclerosis, that has a clinical case definition as well. Because if you don't have a test you can run and find out for sure someone has something, you have to have clinical criteria in order to make a diagnosis. So the diagnosis of Morgellons disease is based on, first of all, subjective findings. In other words, the patient comes in complaining of the classic symptoms, which we'll review in a minute. And I think most everybody here probably knows what most of those are anyway. And also, it is based upon the objective finding, particularly of finding filaments in the skin, unbroken skin, or in the lesions. And it's very important for a practitioner to do a physical exam looking for these filaments, because without the filaments, you don't have the diagnosis of Morgellons disease. So, important part of the whole thing. So first of all, the patient comes in complaining of itching, crawling, biting, stinging. I think you all know all those awful sensations. And they have spontaneously appearing lesions that are very slow to heal, filaments of different colors within and coming out through the skin. Many other type of objects coming out of the skin, seed-like objects, black specks, what we call fuzz balls, for no better name for them. And of course, they have also systemic symptoms like fatigue, insomnia, brain fog, and all sorts of body pain, muscle, and joint pain. And then step 2. Well, whenever a patient comes in to see a doctor and lists a bunch of symptoms, the first thing a doctor does is formulates a differential diagnosis. Now, if you've ever seen the TV show House, they're very famous for doing that. They would all get together and brainstorm, and they would list, a patient would come in with the bizarre symptoms, and up on the board they would list a number of potential diagnoses. In other words, that's their differential. And then one by one they go and say why it could be this one or could not be that one. Now, I could stand here and talk to you for a half an hour at least about all the various skin conditions in the differential for Morgellons disease. There are quite a few of them, at least 15 or 20 that I've mentioned in my book. But it actually would become very boring because it all comes down to the same thing. Each and every one of those other skin conditions, although they share things in common with Morgellons disease, such as lesions and itching and crawling sensations, those other skin conditions do not have the characteristic filaments that you see with Morgellons disease. And that is the one differentiating important factor. So we see many dermatologists misdiagnosing our patients with Morgellons disease, and there are many kinds of, there's a doctor in San Antonio who likes to diagnose patients with Morgellons with prurigo nodularis. That's kind of that is his go-to diagnosis. And, actually when you kind of look at it and read about it, boy, it really sounds similar. But guess what? Prurigo nodularis doesn't have the filaments. And that is the thing that we're looking at here. And so that's basically the difference in the differential diagnosis. I feel like I sound like a frog today. I don't know. But okay. And so in order to really go through the differential and make a decision about what a patient has, the next thing you need to do is find your objective findings. In other words, a thorough physical exam must be performed, and lab work is performed. And a lot of the lab work we do with Morgellons patients is more what we call rule-out work, because there's no specific labs to diagnose Morgellons disease, not commercially available anyway. And so we do a lot of labs to make sure there's nothing else going on. Or the other thing we're looking for, particularly in an integrative a practice like Dr. Cornish and I have, is we're looking for other immune burdens, because if a person has many immune burdens, it's going to help our ability to treat their Morgellons disease if we can identify and possibly remove some of those other burdens that are on their immune system. Now, this is obvious to me, but I think we had a lot of yelling and screaming about this yesterday. It's really not appropriate for a primary care doctor or a dermatologist to refer a patient to a psychiatrist, or even worse, to diagnose a patient with a psychiatric condition without performing a thorough history and exam. That's just simply malpractice. And you just don't make a psychiatric diagnosis as a primary care or dermatologist by standing across the room and saying a couple of words to somebody, Just doesn't happen. So in this particular presentation, what we're going to really focus on more is the part of the objective exam known as visual inspection. In an exam, you have basically three kind of things that we do in this day and age. We have the visual, and we have the palpation, where we feel, and we have auscultation, where we listen, and that's usually when we use a stethoscope and listen to the heart and lungs and that type of thing. So here we're going to be talking about visual, and what we can see both with the naked eye and also with the help of a little bit of magnification. The magnification, minimum of 30, sometimes 60 to 100x is really better. So the dermatoscopes that the average dermatologist has in his pocket usually are somewhere around 10 to 14x. And so even if the dermatologist does think to bring these out and look, he's often going to miss these important diagnostic filaments. Of course, what we're finding is sometimes they don't even take the time to look. That's the unfortunate thing. Now, the first thing you see, the practitioner sees with his eyes, is the general appearance of the patient. And the patients that come in with a Morgellons disease diagnosis, these are sick people. You can see it by the fatigue is evident because of their slow walking, poor posture, slow rising from a sitting position, complexion sallow, kind of a glassy, reddish appearance to the eyes, poor balance on walking and rising. And there's obvious anxiety and scattered thought processes. It's difficult to carry on a conversation because they tend to kind of get lost in the conversation and get scattered. And these are all symptoms of somebody who's sick. This is a sick person. This is not, a mentally ill person. This is a physiologically ill person, and that's pretty obvious just right off the bat. Okay. So, examination of the skin. Now, one thing that I almost always see is cool hands and feet, and you can tell this even because the hands and feet are often reddish or purplish and can even have an appearance similar to Raynaud's, which I'll show you in a slide after this. And some of my patients have actually been diagnosed with Raynaud's, or even if they haven't, they really, I think they could have an auxiliary diagnosis of that. There's also livedo reticularis, and I'm going to show you a picture of that shortly as well. A very mottled appearance of the skin, most frequently found in the arms, particularly the forearms, and in the thighs and lower legs. And cellulitis can be seen as well. Swelling, I see a lot of swelling from the knees down, particularly in the feet, and a very purplish red color to the feet, as well as a swollen appearance. Now, here's an example of a not very severe Raynaud's. The most severe Raynaud's syndrome, you'll actually have just ghostly white and then even blue fingertips as the circulation is cut off. But I see this frequently with my Morgellons patients where they have, their hands have become extremely red. And a lot of times I even see it almost look like a kind of a mitten presentation where the redness is from here on down. Livedo reticularis looks like this. This is a kind of an extreme. Sometimes I see it more subtle than that, But anyway, you may recognize that look of sort of a mottled appearance on the skin. And that is a common finding as well, just in my Lyme patients who don't have Morgellons. And then vasculitis, and by the way, I'm sorry, on my earlier slide I meant to say vasculitis instead of cellulitis. I just caught that now, sorry about that. Vasculitis is the other thing. At this picture here, you might think, wow, that looks just like the Levator reticularis, but it's not. It's a redder look, and this is a very mild case of vasculitis here, but we do see a lot of redness, particularly in the legs of some. And the thing that I find really interesting about all these skin, this kind of interesting aside, is all these vascular problems that we're looking at, like the vasculitis and Raynaud's and Levator reticularis, these are all common in Bartonella. And Bartonella, which is one of the tick-borne infections. And I've always noted quite an association between Bartonella and Morgellons disease, particularly because of the fact that my most successful treatments of my Morgellons patients have always been to target Bartonella in terms of antibiotic protocol. And so this association with Bartonella just keeps kind of popping up. We have found, and some of the researchers have found Bartonella in the lesions. We still don't know what all of this means, whether, what these particular findings are about the Lyme, the Bartonella, the other spirochetes that we see in the lesions. But as they say, the plot thickens, and as we learn more about this, we'll start to learn, what this all means and what the association of all these things is with the presentation known as Morgellons disease. Now, the famous legs. Okay, of course, this is just when a patient comes in, most of the patients that come in to see me with Morgellons disease, they're going to show me something that looks like this. Their legs, their arms, their back. It could be any part of their body. And most people do have a part of their body that's particularly affected. Some people are unlucky enough to have it all over. But usually I have people where it's mostly in my scalp. It's mostly in my mouth. It's, it could be in the genitals. It could, there's usually an area that people have that's particularly affected. So you'll come in, you'll see them, a little problem here with this. Okay, and so these are just more pictures of what it looks like when the patient comes in and presents with these lesions. Now, no lesions does not mean no Morgellons. I've been guesstimating about 15% of my Morgellons patients do not have lesions, okay? Or they may just have a very, very few tiny ones. Now, who knows why this is? It's just probably a function of the severity of the disease in certain people, which probably has a lot to do with their own particular immune burdens or the severity of their disease, who knows. But we see a big, big variance in the presentation of Morgellons disease. I have in my patients everything from people who have just a minor irritation and they're able to go about it their life, but it's just an annoyance, all the way to people who are completely disabled and in bed and disfigured and can't go out in public. So there's a huge range in the presentation of this thing. And it does not mean that those with the milder cases don't have it. It's just, for whatever reason, they do have milder cases. But again, the distinguishing feature is the filaments. So a lot of my patients say, I could not possibly have Morgellons disease because I don't have these lesions like other people have. But no, if they have the filaments, which I can visualize using magnification, well then that's the diagnostic feature, and they do have it. And these people always have all the other symptoms. It's just for some reason they don't, they're the lucky ones. They don't get the lesions, so they don't have to deal with going out in public and having people judge them when they see what they look like. So, the filaments. Okay, sometimes these filaments can be seen without much magnification. I don't know, right now I'm not sure if you guys are seeing the black filaments in this lesion from where you're sitting. Can you see that? Okay, and I have to admit, I'm getting older, my eyes aren't what they used to be. I have trouble seeing filaments without magnification myself, personally. But some of my younger patients with the really sharp eyes, they can see it without the magnification. It's very rare that I can, though. Some of the filaments that are very long, of course, that's a lot easier to see, and especially if you put it against a darker backdrop. I'm having a little trouble with this advancing thing here. Oh, that's right. Hello. Yeah. Oh, okay. Hey. Good. And you might be able to see that blue fiber there. Now, I know for the skeptics, they might say, oh, well, that's just a piece of thread that's stuck on there. But it's not. It's embedded there into the hand. And the thing is, when I'm getting ready to examine skin and look for the filaments, I always rub the skin very brusquely with alcohol, just to make sure there's no attached contaminants from the environment, from their clothes or whatever. And then when I do see something like this, the next thing I try to do is extract it with tweezers. Again, I want to make sure that this is just not an environmental contaminant. But what you will find with the fibers in Morgellons patients is you cannot extract these. You'll try, but you cannot extract them. And usually an attempt to extract them will cause a radiating pain, indicating that these things are deeply rooted and, maybe attached to filaments that are going through the body. This is one of the early signs to me that we were dealing with something quite unique here, because I can still remember the first patient I had with this, taking a pair of tweezers and like, well, let me just pull this thing out, And, no way. There was no way that thing was coming out. And then when I've tried to do biopsies, like punch biopsies in these areas, we can't even really get, with a punch biopsy, you just sort of stick the thing in and twist it, and you can take out a little chunk of skin, easy as pie. But with these patients, with the filaments, you can't get it out because the filaments are so strong. And I can remember when Cindy Casey used to be working with me in San Francisco, remember we used to always try to do those punch biopsies, and we'd get down there and there'd be a filament in there. Oh my gosh, you'd get scissors. Those things are tough as can be. And one of my West Texas patients used to say I could pull a tractor trailer with this stuff, and really, if they could figure out what it is, they could do that. It's some strong stuff. This photograph right here, this is what's on the front of my book out there, because I just thought this is right here in this part of, and so I thought this was so interesting because you can really see the red fibers very well in that. People have a lot of the filaments coming out from right under their nails. Again, this is interesting because, the research work has shown these filaments to be made of keratin and collagen. And, of course, keratin is what the nails are made out of, so they're probably coming from the same cells that produce the keratin for the nails. And, again, more coming out from under the nails. Just a long white one. Another long one. See how fine that one is. You almost kind of need to have a dark background to be able to see that. Now again, it would be very easy for somebody to look at this photo and go, well, that's clearly a contaminant there. It's just kind of stuck to the sticky lesion. But you're just going to have to believe me on this, that that's not the case. It's deeply, deeply rooted there. And I know that most of you who have this illness are going to understand that that's exactly what's going on. Another one coming out there from that lesion. Again, from underneath the nails. Easier to see on the dark background. This is where we start to use a little magnification, and I am not sure if you can see. Do you see the blue fiber that's in under the skin up above the lesion? I'm not sure if you can see that on. Can you see it? Yeah, and this is what we so typically see, those dark blue filaments. This is probably the most frequent kind that I see, the very dark blue, or sometimes it's a black that's almost a bluish black. That's all I know what to say, and I know you guys know what I mean if you have this disease. This kind of thing all the time. You see this all the time. Now, a lot of the doubters and a lot of the dermatologists who see these patients just say, well, that's just a thread from something they were wearing. But we've examined these in the laboratory. Marianne Middleveen, you've already heard her, talking, and Dr. Randy Wymore, Dr. Ava Shapi. These are not cellulose. I mean, that's what it would be if these were from, fabrics or cloth. They're not. They're made from keratin or collagen, which are the body's own proteins. We are making these filaments ourselves. So these are not contaminants from the environment. Now, the really peculiar one is what a lot of patients will just unfortunately say they have feathers coming out of their skin. Now, I think that by stating it this way, sometimes it allows doctors to feel more comfortable about conferring a psychiatric diagnosis because, feathers don't normally come out of our skin. But we have a tendency, all of us, to sort of use this terminology to just describe the look of these things. And yeah, there's a feather-like appearance, to these certain filaments that come out. And, but we just have to be careful about our terminology and not say that feathers are coming out of the skin, but rather that we have things that resemble feathers coming out of the skin. And, this is just amazing stuff to me. And again, I just constantly amazed at how dermatologists aren't fascinated by this because I know from day one, and that was 14 years ago when I first started working with this, the first thought I had was, dermatologists are going to love this disease. I thought, man, aren't they sick and tired of acne and whatever? I mean, this is pretty fascinating stuff. I mean, it's awful to have it, but if you just think of it from an intellectual standpoint, this is pretty amazing stuff. This one is growing right up, that's the ear, so you can see that. Another kind of feathery one there. Patients always talk about the fuzz balls. And again, this is just the terminology we use because we don't know what else to call it. And they do look kind of like little dust bunnies. The filaments are just loosely interwoven. They're not really tightly wound like they are in the black specks. But the fuzz balls sometimes are blue and sometimes they're black. But here's what one of those looks like. About a third of my patients talk about, and this is one that just absolutely baffles me. I have no clue, but say that a black tar-like liquid comes out of their pores. I have watched this come out of people's pores, so I know darn well they're not putting something on there. I have observed it coming through the pores of somebody, and I'm pretty emotionally stable. Some days I wonder, but I don't think I'm delusional. And I actually have sat there and watched a patient while she was talking to me have this just burst out of one of the pores of her cheek. And this substance is, it's tarry-like, you know, it's thick and black. It's not normal stuff. And one of my patients was actually getting a lesion sewn up in an emergency room, and the black tarry stuff started to come out. And the doctor freaked out. He just said, I'm stopping. I'm not going to sew this up. And I said, well, but wasn't he interested? I mean, what did he say about it? And she said, he just ran out of the room. I'm like, you know, I don't know. Don't people get interested in these things? I mean, that happened. And again, this. Yeah, that's a typical situation. Oh gosh. Well, there's always a way to you know, some reason to give for it. But it's interesting, certain symptoms every Morgellons patient shares in common, and then we have this other group of symptoms that, you know, say maybe a third or a half might have, and not every single person has that particular symptom. Now, the crystal exudates, I really don't think every one of my patients, but I don't have the statistics on this one like I do on the black tarry. That's a third. But the crystal exudates, again, mind-boggling. Have no idea where this fits into the whole picture. But what happens is there are these very, they come out, they look like this, but they're so fine they can almost evaporate. They can just end up as powder in nothing flat. And the other thing that is related to this, I think, is the, again, this terminology we use, I realize we put ourselves at risk of people thinking we're crazy, but, you know, what are you going to do? You have to have terminology for this stuff. And the other thing is the glitter, you know, hello, the glitter. Okay, so doggone it, these people have glitter on their body. And I actually, I talked to a patient here yesterday and who said she had gone to a dermatologist and she didn't even realize she had the glitter yet. And the dermatologist said, you have glitter all over your body. Did you put some kind of a makeup or cream on with? And she said, no, no. She said, I might have some on my face. And he said, oh no, you've got glitter coming out of your toes. And so here was a case where the doctor recognized it even before the patient did. And so the glitter, I've seen it on the patients, and you know, a lot of people will think when the women have it, oh, they're wearing some kind of makeup that's got the little shiny things in it. But you know, I see it on the male patients too. I don't think they're wearing makeup. I can't tell for sure, but I mean, there's something going on here with the glitter, and I don't know how to describe what in the heck that could be. But right now, we're just looking for signs here that these people fall into a diagnostic group. We're going to save the questions to after, I guess, if that's okay, yeah. Now, another puzzling thing that not every single Morgellons patient has is what we're going to call scratches, linear scratches. This is on a woman's breast. Now, many doctors will just say, oh, for crying out loud, you scratched yourself. You know, okay, you did it in your sleep and you didn't know it. But the thing is, two things that are bizarre about these. One, they will appear in places where the patient could not even reach with their hands, so that makes it hard to believe they could have done it during their sleep at night. And also, people will actually watch these scratches appear right before their eyes. They just watch them happen. And so I cannot explain this. I just am reporting what I see here and the type of symptoms these patients have. This one's a little harder to see because it's right on the bone there of the arm, but this is another one of those scratches. And then some of them look more like this, which actually, once again, going back to the Bartonella, this is a very typical skin pattern of a Bartonella patient. and the striae that we talk about in Bartonella. So again, that little, association I keep seeing with the Bartonella. Here's another bizarre one. Again, I just have to call these burrows. I don't know what else to call them. This is under somebody's knee, and these are just like a little elevation. They're always the same color of the skin, slight elevation. This is not dermatographism, which is when you go like this and then you will see a red mark. No, these are raised, and there's no redness. It's the color of the skin. And again, here it is right above a woman's left breast. So, now, the most unfortunate souls of all are the ones that have the very, very deep, deep, deep lesions that are very hard to heal. These are, what are you going to say about these? You can't look at these and think a person's doing these to themselves. There's just no way. And people with these deep lesions that start out like just a deep hole go from place to place, doctor to doctor. They always try various creams on them, antibacterial, antifungal, corticosteroid. Nothing ever helps. And as they get worse and worse, they go to wound care experts. And the wound care experts try everything in their bag of tricks, and they can't figure out what to do either. Nothing works. And they just get worse and worse and worse and bigger, and I've seen these things just erupt in people. There is no way a human being would do this to themselves. Now, in this particular case, the patient had to meet the public daily. The last thing he wanted was to have his face look like this. As a matter of fact, it cost him his job. And so this is a deeply, deeply distressing thing to happen to you, both in terms of pain, but also even just in terms of your pride, because you have to walk around looking like this. This is during a period of it having temporarily healed a little bit. But even then, as you can see, there's the deep scarring. Okay, this is a man's testicle, where we also had the deep, deep lesion. Now, for some reason, my male patients, in a number of cases, I've had male patients where their worst area seemed to be their groin. And they have terrible, terrible pain, just layers of skin come off, and deep, deep holes. And what happens, one of the reasons these areas are so painful is they're filled with, and again, I'm got to borrow a word, I call them shards. they're shards of collagen that can be hard and painful. And when they're in these holes, there's a tendency for people to want to remove them because they're causing extreme pain. Now, unfortunately, because they dig at the sores and try to remove the things, patients are often, once again, considered mentally unstable because what are you doing digging away at that thing, But what's not realized is there's stuff in there causing extreme pain, and when they remove it, the pain is relieved, at least temporarily anyway. Now, this whole thing, these pictures aren't for the faint-hearted. I'm sorry about that, but you got to know what this disease does. The next picture, also in the groin of a man, that it just shows too how it just kind of eats away. Every topical thing doesn't work. All wound care methods don't work. Doctor after doctor after doctor says, I have no clue what to do for you or what this is. Okay, here's what I'm talking about when I say like a shard. That's next to. So in this particular patient with the genital problems and the testicular lesion, wound. I would call it more of a wound. This is an example of one of the things that was dug out that was causing extreme pain, and this is very firm, collagenous sort of thing. After one session of digging things out of the testicular lesion, this is the bloody mess that was left after this with tissues and Band-Aids and all. This particular patient, by the way, does happen to be anemic, not surprising, with all the blood loss. And this was after one session of digging these shards out. And this shows you how many there were and the different sizes. And these things cause a lot of pain, a lot of pain. I mean, I've got patients that are on pretty heavy-duty pain relief medication because we're talking some severe pain that a lot of these patients have. Now, the scalp. The scalp seems to be an area that's heavily affected for many people. And I just talked to someone here yesterday that said, I'm not sure if I have this because really I only have it in my scalp. But, well, you still have it. Everybody has a place that it's worse. And the scalp is one of the areas it is, and probably because, the hair follicles there. And that's, so often the filaments tend to grow out of the same follicles as the hair. So when you examine the scalp, you see hair loss. Hair loss is common, and I'm not sure the percentage, 5 to 10% become totally bald, lose it all. There's a lot of lesions in the scalp. There's a thing some people call, it's sort of a fuzz ball. I'll show you a picture of this. I've had people call them, so we have to use terminology. What are we going to do? We don't know what to call this stuff. So we have to, people sometimes think it's like nests or something like that. And I'll show you a picture in a minute and you'll see why. They look like cocoons. And then there is this peculiar raised area on the crown of the head that I see so often that has a mushy sensation to it. It's just right there. Again, not every patient has that, but it's a common enough finding. So here's an example of someone with a lot of lesions and a significant amount of hair loss on top of the head. Common thing for me to see. Here's somebody with a primary lesion right at the crown, and that is that vulnerable spot for some reason, where I had one patient develop a huge gaping lesion right there at the crown, totally open, had been to everyone to try to heal it, and finally found a plastic surgeon that would agree to suture it together. It was very hard for her to talk him into doing this, but just for cosmetic reasons, she just was very embarrassed, obviously, to have this big gaping lesion that big on the crown of her head. And so the plastic surgeon did sew it up for her, and very shortly after, the sutures ruptured and it opened up again. And then the plastic surgeon accused her of ripping the stitches out. And she had spent a lot of money to get this plastic surgery, so she was pretty offended. Why would I do that? But, this is what our patients endure, right? A lot of insults all the time. Okay. And there is a case of a male patient who totally shaved his head, and you can so clearly see that mound I'm talking about on the crown of the head. There's a mushiness under it, which is, very, and I'm not going to attempt, we all have a lot of theories about what's going on and what the mushiness is, but my purpose here is more just exam findings. I'm not a researcher, and I'm not going to put out any theories about what is causing these various things. I'm a clinician. I've been looking at this stuff for 14 years, and I'm all about just showing you what you can find and what you will look for and what you can see in these patients. Now, here are the cocoons. Again, people call them that, but a lot of times when their hair comes out and hair loss is significant, they'll see these little white areas right there. And you can read in my book more about too, about the theories of what these various things may be. Again, a lot of them are just theories at this point. This has always really amazed me, the things that are going on in the mouth. The roots of people's teeth, the bases of people's teeth turn black. I've seen it myself where, just black along the ridge there. The teeth become, and I mean, I know when I have people in the audience that are skeptics, I know the whole time I'm talking, they're thinking, yeah, right. But the teeth become hollow. That is what happens. I have had dentists call me all over the United States saying, what the heck? I've never seen anything like this in my career. These people, it's not they're getting cavities. Their teeth are crumbling out. They're hollow and then they crumble. And they start out black and then they crumble. And so it's always been my supposition that there is some sort of leaching of calcium or something going on, which is interesting. And of course, more studies would be a good idea there, so we could see, do these people also have osteoporosis, or what other things may be going on that might indicate a leaching of calcium. But what's going on with the teeth cannot be overlooked as an important part of this whole disease process. And now, I don't know if you can see that, but on the tooth, on the upper left side, do you see a black filament coming out? I have many patients where the mouth symptoms are the worst, and they have copious filaments coming out of their mouth, their gums, their tongue. It's just an awful, uncomfortable sensation because it's just nonstop. And there's nothing really good we can do for this symptom. I mean, various mouthwashes are tried, whatever. It's just all part of the process, and hopefully as we treat them with antibiotics and everything, the symptom will go down. But many of these symptoms, there's no way to really deal with the actual symptom until we get to the root of what's causing all this. Now, of course, examining the skin with magnification will reveal so much more than just with the naked eye. And that's the problem we're seeing, is that most doctors will not take the time to examine the skin. Well, most won't even take the time with the naked eye, but they definitely don't take the time with the proper magnification. And you're not going to see what you need to see unless you take this time to do this. Now, when you use some magnification, 30x you're going to see better, that's for sure. But it's still somewhere, you can go too high. Somewhere between 60 and 100 is good. A lot of times you go up to 200 is too much, and it's hard to see then. But I have to say that for me personally, because my eyes are not that good anymore, I really need this magnification to see these filaments. We see red ones, black ones, blue ones, kind of a bright turquoise, but then a dark blue as well. The red is a sort of a crimson color red, as you see here. And there are a lot of explanations about the various colors, and I explain that more in the book about the theories of some, but right now, all of the color theories are really more educated guesses. So much has not been proven yet. This one here, I probably shouldn't have put this under the magnification, but you can still see some filaments coming up. Again, the nails are a place where you always want to look. I've had people come in and they didn't even know they had them under their nails, and that's always one of the first places I look, because I know I'll find something there. And when I look up under the nails, then usually I'll find something. And that's just more of a magnified fuzz ball, as we call it. And then when you have the various exudates and the scabs that are examined, and of course a lot of these are examined in the laboratory, this one is courtesy of Dr. Randy Wymore. He presented a number of years ago at this conference. And this shows how the filaments do wrap tightly around each individual hair. And this is why patients consistently say, my hair has changed texture, or they may make comments like, my hair is not my own. And unfortunately, that is a comment that leads physicians to feel like, wait a minute, that's bizarre. But people are trying to tell you, that's what I think doctors need to realize, is when patients say things, you got to really listen, because usually they're telling you some important information. You know, if a patient says something like, I feel like I'm drowning, you don't want to ignore that. I mean, you want to like look at his lungs, because he probably has fluid in his lungs, you know. And so there's things patients say that may seem wacky to you, but they always give you a very good clue to something. And so when people say, my hair is not my own, what's happening is it doesn't feel right. And the reason it doesn't feel right is these doggone filaments growing out of the same follicles are wrapping tightly around the hair, and therefore the hair, of course, feels much coarser. It doesn't feel like theirs. And then the other thing is, that's always interesting, is people whose hair has already gone white comes in black. Because it's not hair, it's filaments. And people will be like, well, what, are you dyeing your hair now? And no, I'm not dyeing my hair. You know, but their white hair starts to turn black again, which is not a normal occurrence. It's not what we usually do, is have white hair turn black. But this happens a lot of times with my patients. Again, this shows microscopically that the slime, the goop that people always talk about, the slimy feeling on their skin, the soapy feeling. People say they have to take 3 or 4 baths a day. This is probably due to the alginate, which has been found in the exudates. That is a slimy kind of substance that we see as part of biofilm. But it's not something that should be ignored. Whenever a patient comes in and tells a symptom, it might sound wacky, but they're trying to tell you something. And if a patient comes in and says, I have to take 3 or 4 baths a day, that's not something you laugh off and ignore. They're telling you something. That's really important data. And so I feel like that's the thing. We have to be really listening to patients. And I find in our hurried managed care and kind of environment we're in now, a lot of practitioners aren't really listening. You know, and these are all important clues that people tell you. Again, just the filaments in a scab, blue filaments in a scab. These filaments here, the kind of ribbony kind, were vaginal. And believe me, these things come out everywhere. This is courtesy of Marianne Middleveen. Over there, the black speck at about 2 o'clock, magnified. No, we'll get to that. We'll get to that later. Okay, and here's some. I think this is a particularly beautiful picture of the blue fibers here. And this is a picture of one of the blue fibers under microscope. Again, just more looking at the exudates and the filaments. Now, probably the most interesting thing, and is there a timekeeper? How am I doing on time? I don't even know. Anybody? Nobody's yelled at me yet. Oh, perfect timing. Okay, yay. Okay, this is probably one of the most interesting things about this disease, is what happens with these scabs and what happens underneath them. The scabs that form over the lesions are extremely hardened skin, not like any kind of scab you normally see in any kind of normal healing process. And this hardened skin is very difficult to remove. I often give patients prescriptions for collagenase, which just eats through that skin and so that you can remove it. Now, the reason patients pick at this and want to remove it is because there are projections underneath the scab that dig down into the skin and cause tremendous pain. They're not picking at this because they're pickers and they're neurotic. They're picking because they're having pain and they're trying to remove the source of their pain. Once you get these scabs off, and they're very difficult to remove, but they're certainly motivated to do so, you find very weird things growing out from underneath the scabs, something you would not expect to see. You can kind of call these projections various names, you know, sort of plugs or something. But see, these things, right, this scab is turned upside down, and those right there, those sort of gelatinous projections, those were growing down into the skin. So naturally, those were causing pain. And as soon as somebody's able to get one of those scabs out and pull one, it's such a relief, a temporary relief. And this, again, shows some of the projections out from underneath the scab. This was a very small scab removed and just showing that one projection underneath it. But again, I mean, of course you want to get those scabs off of there if they're causing that much pain. But you know, it's a funny thing when you pick at a scab. You know, that's always considered something. When you were a little kid and you picked at a scab, your parents say, "Don't pick at that." and so people are really not supposed to pick at their scabs. But this is a very different situation we have here. This is not like your usual scab you got from your skin knee. These are some growths going down there causing extreme pain. And see, here we have it again. This is all coming down from one of the scabs. All these growths down here were going down into the skin. People sometimes look at that and they'll go, "Oh, those are larvae." No, they're not larvae. They're made out of the body's own proteins. You know, it's not normal, but these things are made out of collagen and keratin, the body's own proteins. Again, a scab turned upside down, showing all these projections under it. See, these, you know, plugs or projections or whatever you want to call them underneath the scabs. Pretty amazing. Now, these, you've heard us talk about bovine digital dermatitis. And this was the cow disease that Marianne Middleveen first thought, this Morgellons kind of reminds me of this BDD, bovine digital dermatitis. And if you look at this picture here, which is from a human, it looks so much like the scabs removed from those cows with that spirochetal disease. Those same plugs that go down and cause them, and that's those cows become lame because it's painful to walk. They can't walk with these things. So this is just a potpourri of different things that you can find on examination. Thanks to all these people for helping providing photographs and everything else. And I'm happy to, I'm going to be selling and autographing the book on the break after this for anyone who hasn't managed to procure one yet. And I'll be happy to answer any questions anybody may have. Thank you very much.